by Anupama. Uh, and several people here have been asking questions about SIR model and epidemics and so on. So this is the first epidemic talk, and I'm sure if you have any questions about SIR model or related epidemic models, Anupama is the right person to ask because her entire background is like modeling epidemic diseases. And it's a great pleasure to have Anupama here, of course. So Anupama did a PhD from EHU, which was again on how interactions between social factors and epidemics play out in either stopping or making epidemics go faster. And then she was at IMSC for a couple of years, where because Sashi was also here at that time and he was here, so between three of them, they managed to work out some wonderful interactions between game theory, social dynamics, epidemic dynamics, and so on. And then she left for a postdoc abroad, and then for several years back, she joined BITS Goa as a faculty member and has been working on epidemic models and their ramifications since. So, Anupama, please.
Thank you for such a nice introduction. All right, and thank you everyone for being here. So, you know by now that I am Anupama and I work on epidemic models. So you know what an epidemic is, right? Now everyone knows epidemic because we just saw a COVID pandemic. So epidemic is essentially, just for the sake of completeness, I'll just say that, so an epidemic is essentially a spread of an infectious disease or outburst of a infectious disease. And when it's called pandemic is when it spanned over large geographical area. For example, COVID was a pandemic because it affected the whole world, right? So that's why it's a pandemic. But if an epidemic or an infectious disease is confined to a small area, small geographical area, then it's called an epidemic. Okay, so epidemics. So epidemics definitely, or a spread of an infectious disease definitely has a biological component to it. So there is a pathogen, there is a bacteria or a virus which is going to infect a person, or what we call in epidemiology is a host. So it's going to affect a host, and then also that's the way of virus or pathogen to survive, right? By affecting, because it's a pathogen, it cannot survive on its own, so it needs another host to survive on. So then it has a biological aspect to it as to how a host enter the immune or crack the immune system of a host, and then how do they survive by doing that, how does it hop from one host to other, and how does it harbor it, the host or the immune system of the host. So that's the biological aspect of the disease. So today we are not going to talk about the biological aspect of the disease. We are going to be focusing on the social aspect of the disease, because human behavior or most of the disease that we usually study affect human beings, right? Because we probably won't, like we do in veterinary we do study the diseases which affect the animal, but mostly from the modeling point of view we mostly focus on the diseases which affect human being. It could be a disease which affect both, right? It can have, a disease can essentially have two hosts or multiple hosts, right? It can affect human as well as, let's say, monkey or a cattle population or any other host, right? But we mostly focus on the diseases which affects us as well, right? So and if it's affecting human, then obviously there is a human behavior or how human respond to that threat, because epidemic, me being sick, is a threat to my well-being, right? So how do I respond to that threat is very, very important and very, very determinantal in figuring out what will be the core future of the epidemic. As to so I have a threat, and how do I deal with it? It's going to affect how so who is going to win, the threat or me, right? So so this is when the behavioral part or the human behavior come into picture, and how does it affect the course of an epidemic is what my area of research is. Okay. So pandemic. So this is a figure showing how human have evolved alongside all these diseases, pandemic, epidemics, essentially the infectious diseases. So it starts from back from 1347, Black Death, and then pandemic since 19th century are like first pandemic of cholera, various pandemics of cholera actually, and then the prominent one in the past through few centuries is 1980s Spanish flu, which was the first pandemic during the modern medicine era. So it taught us a lot of things because we were equipped with these tools of modern medicine, and how we actually dealt with it taught us a lot of things. Then recent the ongoing pandemic of or epidemic of HIV/AIDS. Then there was a SARS outbreak in 2002, 2004. Then around 2009 there was a influenza pandemic or a swine flu pandemic, and this is actually when I joined my PhD. And that's for the first time. That's probably the first pandemic that I remember. And then we saw people wearing masks. Suddenly, people were wearing masks. So now during COVID, we all have worn masks. But that was for me first time that I saw people wearing masks on the street, and that made me question as to. So then also we saw a lot of television advertisement on television saying that, oh, these are the behavior practices that you should be following. And that then a natural question to ask is, okay, if all of us started following these mandates or wearing masks, etc., then how does it going to affect the epidemic, and how essentially these media campaigns which are targeting to these certain practices, how these media campaigns suddenly, why they are running these media campaigns, right? And then how they are going to actually this new information that is coming through, how it's going to affect the future of the epidemic. So that was the focus of my PhD work, where I was looking at how these new information which is coming in is going to affect the course of an epidemic. And then recently, as I said, in 2019 we saw this pandemic, COVID-19 pandemic, where now we have all seen how this is the first pandemic in the era of social media, and then obviously that added another dimension to it, because now everyone is connected to everyone, right? Not physically, but through information. So how excessive of the information affected the epidemic is something that we learned during this recent pandemic of COVID-19, which, as I said, it is the first pandemic during the in the era of connectivity or social media, right? So what I want to focus here is that humanity has evolved alongside these infectious diseases and pandemics, and we have coexisted for a long time, and over the course of this coexistence, we have learned a lot of things. We have learned a lot of lessons from how we dealt with these pandemics throughout ever adapting era. So as I said, there was a Spanish flu was during the modern medicine, and now the recent COVID pandemic during the age of connectivity and social media, right? So how do we evolve? So we have been coexisted, and what do we learn? What have we learned from this epidemic is, so what are the key lessons that we learned from going through all these epidemics and pandemics throughout the history? First is early detection and rapid response is always the best, right? So if you detect an epidemic early, so early detection is the key. So if an epidemic is confined in an area, and then you can just curb it there, right? So that is always going to be the best policy, but that's obviously not always possible, but that's the first course of and the best course of action, that you respond rapidly, and early detection is the key, right? And this is actually something that I'll talk about in my next talk as well, where we're looking at the different kind of information on which people are acting, and how early detection can actually help in terms of vaccination as well. So that we'll discuss in the next talk. So as I said, first is the early detection is always best. Second is global collaboration, because now we are, as I said, we are in an age where everyone is connected to everyone. So then we need global, in terms of research and development of vaccine and medicine. It's like global collaboration is very, very important, from curbing or eliminating, or rather managing the spread of an epidemic. So for example, we can, if there is a global collaboration, we can have travel restrictions, etc., across the globe, right? Obviously, third point is strengthening the healthcare system. If your healthcare system is strong enough, we will be able to curb the epidemic. That's goes without saying, because if we have good medicine, good treatment, and then we will be able to deal with the epidemic better, right? If we don't have it. Effective communication again is very important. As I said, we live in a time which is of connectivity, and people, so information is the key. So we need to know, and the correct information is even more important, because there could be negative information as well, right? So and human behavior, as I said, from the point of view of human behavior, we act on the information that is available to us. So the availability of information or effective communication is very, very important. Also, it's important in terms of like diseases like HIV, AIDS, where there's a lot of stigma around it. So communication helps people coming forward and taking the kind of or seeking the kind of treatment or help that they want. So communication, effective communication is very important. And the last is the human behavioral impact, is what we have learned from going through all these epidemics, is that human behavior actually plays a very, very important role in shaping the trajectory of an epidemic. Okay, and as I said, that's what we are going to focus in this talk. So historically, human pathogen infection interactions have been documented through anecdotes. So there's this book called Plagues and People, which actually talks about how plagues, so different occurrences of the plagues have actually shaped a lot of things. So it doesn't even it has more to offer, or it affects not only the health of a population, but it changes a lot of things, like politically also, and in terms of research and development as well. So it changes a lot of things. So how plagues not only affect the health of people, but more than health, right? Then we saw during COVID-19 that people were wearing masks, and the nationwide lockdowns were imposed. We changed our travel plans. Obviously, we were socially distancing. We used to go, if you all remember, we go to the shop and we will be just standing like a good distance apart from each other. So these kind of impact or these kind of responses came when we know that there is an epidemic, and we adopt all these practices to minimize the chances of catching infection. But so there's been anecdotes, and then we have also seen all these things happening in real life when we face this epidemic, this COVID-19 pandemic. But and again, behavioral changes are also cited sometimes as to explain the drop in the transmission rate. So for example, if you are looking at the epidemic and suddenly we're looking at the number of cases, how they are increasing, and suddenly there is a unexplainable drop in the cases. Sometimes we say that, okay, this could be possible, that it is because of the fact that now that people are more aware about the prevalence of this disease, they are going to take some protective measures, and that's going to reduce the transmission rate, and that's how the curve is going down, right? The cases are going down. So it's been documented as sometimes used as to explain the reduction in the transmission rate as well. But what we want to do is we need a concrete evidence, or we need to see how do we actually incorporate these observations that we have made in a modeling process, right? Because as I said, maybe so even if you are a mathematician, or you are a public health worker, or you are or you're just a curious person, right? You want to know how epidemic progress. It's very interesting to know how epidemic is progressing and how these behavioral changes will affect the epidemic trajectory, right? So we're trying to understand that, and the one thing that we can do to understand any system is where a lot of things are at play, right? You can understand that here the epidemic is spreading in the population, and then the population itself, so it's spreading through the context, and then now there's information coming in, then the individual, the host within which this epidemic is spreading, now they are adopting some protective measures to stop the transmission. So how this information that's now come in because about the epidemic is changing our behavior, and now there is a loop, right? So then change in the behavior will also affect the epidemic, so or the course of the epidemic. So there's a lot of factors which are involved in it, and whenever we try to understand any system which has a lot of feedback loops and a lot of factors involved, the best way to do, how do we proceed about it, how do we mathematically try to understand real world situation, physical situation, is through a model, right? We try to model this situation, right? Right? Okay, so we try to model this. So the question that we are asking through our model is, can individual behavior change the fate of an outbreak? Can it change how epidemic trajectory, how epidemic will pan out? Just through behavior changes, can we say something about how the epidemic will pan out, right? So in order to model this or answer this question using modeling, what we have to do is, so we have to first understand how do we model an outbreak mathematically, right? Because I'm going one step ahead. I'm saying that I'm trying to model how behavioral changes are affecting the epidemic, right? But I don't even know at this point how do I actually model the spread of an epidemic. So first question I ask is it even possible to come up with a model, a mathematical model rather, which can mimic in some way the spread of an epidemic? Okay, so that's the first question that we are trying to address. So once we have established the fact that I can essentially capture some element of a spread of an epidemic, because obviously it's a model, so it's a simplification, right? You know that if your model is as complicated as the real system, then there is no point of model. A model shouldn't be so complicated that it's not transparent anymore. So model, why we, especially mathematical model, it might be true for the machine learning models, but in mathematics we go for mathematical model when we want to have the understanding of how the model is also working, right? So we want to have some degree of analytical traceability if we are going for a mathematical model. So can we even do that for an epidemic? So that's the first question that I'm going to address. And once we have established that yes, we can do that, if we can, then we'll move forward and we try to modify these models to see can we include these behavioral changes in this epidemic model. Okay, so the first what we are going to do is we try to model an epidemic or a spread of infectious disease, and then once we establish a mathematical model for an epidemic, what we are going to do is we are going to modify it in order to incorporate these behavioral changes into the existing model that we have for a spread of an epidemic. Okay, any questions at this point? All right. Okay, so let's address these questions one by one. So let's focus on the first question first. So how do we model the outbreak mathematically? So first of all, in order to model a disease, we first have to work on a couple of things. We have to make some, so it's again, when we try to make a model, we have to list down some assumptions, right? So we have to, as I said, models are usually a simplification of a real world problem. So we have to make some assumptions about it. So the first assumption or the first question that I'm trying to address here is what is the mode of transmission of the disease? Because there are diseases like let's say diabetes, right? It's non-communicable. It cannot be transferred from one person to other just by being in the proximity. So then that kind of disease I'm not interested in modeling, because then I cannot, there is no interaction, right? So I cannot model that using a mathematical model. So I'm going to focus on the disease which are transmitted through the direct contact. So what is the mode of transmission? So there are different mode of transmission in for communicable diseases as well. So there are two categories of diseases. One is communicable, other is non-communicable. So we are focusing on the communicable ones, not non-communicable, right, like diabetes, etc. So for mode of transmission of a communicable disease, so first mode of direction is the direct contact. You come in direct contact with, so there is a healthy person, there is a sick person. Yes.
Just curious, can there be non-communicable epidemic?
There could be, right? But it's not transmitted from one person to other. So epidemic is if there is a occurrence of a particular disease in an area, the numbers started shooting up, right? So that's what we call as epidemic. But it's not a infectious disease. We are focusing on infectious disease, right? It's a lifestyle disease. So there are occurrences, like now they are calling, in some countries they are calling obesity also as an epidemic. Rather they use the word epidemic, because it's even depression is epidemic, because a lot of people are being affected by it. So the number of cases are on rise, but they are not through interaction, right? They are just the reasons behind those epidemics are different from what we are going to focus here. Okay, any other questions? No. Okay. Okay, so in terms of infectious diseases or communicable diseases, there are different mode of interaction. So one is a direct contact. So there is a healthy person, there is a sick person, and they come in direct contact with each other, and then the disease, there is a high chance that disease will be transmitted, right? Then there is an indirect contact as well. For example, in these cases, the pathogen can live on a surface for a long time, for a significant amount of time. So if a sick person touched a particular surface, and a healthy person also touches that surface within that significant time, they can catch the pathogen, right? So coming into contact with the areas that have been contaminated by germs. Then there are vector-borne diseases like malaria, dengue, yellow fever, right, where there is a vector. So two person will come in contact, so a healthy person will come in contact with a sick person, they will not catch infection, but there is a vector. So as I said, we call in the person, the human, as mostly host, and then there is a vector which is going to transmit disease from one host to other, right? So there is now another element to it, which is called vector. It's not the vector that we usually use in mathematics. So for example, mosquito is a vector, okay, for malaria and dengue. So it bites the healthy infectious person or sick person, and then it bites, and then the pathogen enters the vector's body. It stays there in their blood, and then they bite the healthy person, and that's how the bacteria or the pathogen is transmitted. Okay, so it's not a one-to-one contact, but through a vector. So there is another vector at play. Then there are foodborne diseases, for eating food which is contaminated with the germs, and for example, stomach bug. And then there is a waterborne diseases, which I mean, you can keep these two in same categories, foodborne and vectorborne, which you contract by ingesting the contaminated water, like for example cholera, right? So here also, in case of cholera or any foodborne disease, if a healthy person come in contact with a sick person, they are not going to get infected, but it so happens that when the sick person is shedding this pathogen in a water, and then if a healthy person ingests that contaminated water, then they get the disease, okay? So direct contact again is not in picture. So so for all these kind of different modes of transmission, we need different modeling framework, right? So for example, if I am talking about the vector-borne diseases, right? So if I just if I just consider the human or host population, that is not going to be enough, because there is another element to it, which is the vector, and the vector has some dynamics going on, right, within the vector population. So there is a host population where some people are healthy, people are getting sick, and then they are getting recovered, and blah blah blah. So they have their own dynamics going on, and then there is vector, which is again, they are getting sick, they are contracting the infection, and then there are healthy vectors as well, or mosquito as well, and then they have their own dynamics going on, and then they are coupled with each other, right? So there is a host population, there are vector population, and they are coupled through a crisscross interaction, because when a healthy mosquito bites on a sick host, then they catch the infection, and same vice versa. So if a healthy person is bitten by a sick mosquito or vector, then they contract the disease, right? So here you will have so you will have a different so what was your question?
So why are the both different in terms of model?
Yeah, as I said, you can combine these two, because essentially here you are looking at what is the number or the density of the bacteria or the pathogen outside the human body, right? Because you are not looking at the infected host, you are also looking at how much they are shedding and what is in the environment, and which is being ingested, be it food or vector or water, and that's how they catch the disease, right? So you can combine these two. It depends upon basic reproduction number. I will talk about it. So as I said, so we will be again for this talk, I will be focusing on the direct contact. So diseases or the mode of transmission as a direct contact. So diseases which can be spread through the direct contact. So the healthy per host and the healthy. So I am not going to focus on rest of the mode of transmission. We will just focus on the diseases which are being spread by when a healthy person come in contact with a sick person, and they come in a direct contact, and then how do that is then the disease spread, right? Although you can very easily extend these ideas to any of these mode of transmission. As I said, if you want to extend it to a vector-borne disease, you just have to consider another population of vectors and then consider their dynamics as well. Similarly, for waterborne or foodborne disease, you have to take into account that there is a bacteria or there is a pathogen which is in the environment, right? And then you write the equation for that and how it is changing. So dynamics of that bacteria needs to be taken into account. So then it's just you have to understand that the infection won't happen if a healthy person come in contact with the sick person. It's more complicated than that. Okay. So we will be anyway for this talk we will be only focusing on the direct contact. So as I said, we make some assumptions, right? Apart from direct contact, we have to make more assumption because epidemics is a very complicated or elaborate rather phenomenon. So in order to model this situation, I make some assumption. The journal setup goes like this. So we consider the population is large first of all, because because I'm making this assumption because I want to stick to the differential equations. Okay, so I will be focusing only on the deterministic equation, right? I don't want to go to the stochastic part of it. Again, you can easily extend, once you have the idea about how the deterministic system works, you can easily extend these ideas to a stochastic system, right? So, but for now, we'll just focus on the deterministic one, and for that we have to make the assumption that population is large, so the random differences can be ignored, right? So what I consider is that I have same immunity as any of you, right? Which is probably a big assumption, but when you are looking at the whole population of a city or a country, then it's a valid assumption that on average everyone will have, like, maybe there will be some outliers, but on average everyone have same immunity. So their chances of catching infection is also almost same. Okay, so I'm making this assumption that each individual is identical, so that I can write the differential equation. Otherwise I have to do like agent based simulations. So population is large, so random differences are ignored, which are obviously relevant to the epidemic, right? Okay, initially we are going to neglect the birth and death also. Yes. Treatment, right? So access to the treatment also. And then when we go to the human behavioral part, then there is a huge component as to how I respond to these, right? That is also perceptive, right? I might wear a mask or might not wear a mask. It doesn't mean that everyone is going to wear a mask, right? Same thing goes for vaccine. Maybe I want to get vaccinated. Maybe I'm anti-vax, right? So I'll be like, oh, I'm not going to get vaccinated. So that is a decision that I'm making right now for myself. So it's an individual. So some might get vaccinated, some might not get vaccinated. That is introducing a heterogeneity. So when I am modeling it, I'm considering that if I'm considering that people are wearing mask, I consider everyone is wearing mask, okay, and everyone is getting same access to the treatment, so they are all recovering at the same time and on average, obviously, and then everyone is equally prone to the infection, right? Because even if I'm not taking the human behavior into account, I can say that I just stay at my home, I never go out, right? So there is a chances of me catching infection than someone who is going out every day, meeting a lot of people. They have a more chance of getting infection. Their probability of catching infection is much higher than me, who is sitting at home all day, right? But then when I model, I consider that each person has equal chance of catching infection. Another assumption is of homogeneous mixing, that will probably on the slide. So as I said, for now we are going to ignore birth and death also, because I'm right now focusing on an epidemic, so I assume that this epidemic is a short-lived epidemic, right? So it's a short duration epidemic, so there's just number increases and then it dies out. So I would consider that there is the number of death and birth that happened during this course of period is negligible, so I just ignore I just ignore it for the time being, but again we can easily incorporate it and I'll talk about it, right? Then I assume that the latent period of the disease is 0. That is again I will relax all of these except for the population is large and random, because then I have to go to the stochastic differential equations, so I don't want to do that. But apart from that, we'll relax all these and then see what happens, okay, and how can we relax and incorporate these changes in the model. So now I'm assuming that the latent period of the disease is 0, which means the moment I catch the infection, I start infecting other people, which is not true. Usually, if you look at the biology, it happens that once you catch infection, then it will take some time for the pathogen to reach a point where you start shedding the bacteria and then you infect people, right? So there is a latent period before you become infectious. So you are infected but not infectious yet, okay? So that's called latent period, and for now I'm just going to ignore it. I consider that the moment I catch infection, I start shedding it, and then I can be, as soon as I'm infected, I'm infectious, okay? All right, okay. Then individual who recover are assumed to be immune. So once I recover from the disease, I am immune for lifelong, okay? So I cannot catch the infection again. This is very easy to relax this assumption. So right now I am assuming that once I recover from the disease, I am immune through the infection forever. And the last and very important assumption is the population is homogeneously mixed, which means that we individuals are actually like molecules, and we are just like randomly walking around, and everyone has equal probability in coming in touch with the other person. So we can always have like these interaction which will lead to the so we are molecules of so we can being bombarded by like any other molecules, right? There's a high chance that I will get in. So each one is connected to other, or each person in the population has equal probability of catching infection from a other person in the in the population, which is again not true, right? It's a very strong assumption that I'm making here, because you know that we have a contact structure, right? So if there is so I live in Goa, so I live in a campus, right? So I have obviously more chances of, so let's talk about Chennai. So let's say we are on this IMSC campus, and if there is a case on IMSC, then I have more chances of catching that infection rather than someone who is living in Vellacheri, right? So, but here I'm assuming that each individual has equal chances of catching infection. So that's what we mean when we say that population is homogeneously mixed, okay? So, okay, so this is a general setup. So with these assumptions, now we are going to try to formulate or build a model, epidemic model. So this is the first, the simplest mathematical model which was proposed by Kermack McKendrick, and so what they did is they considered that the whole population can be divided in 3 categories or 3 compartments. That's why these models are also called compartment models, okay? So they consider that the population can be divided in 3 compartments. One is this compartment which is called susceptible individuals, susceptible individuals. This compartment contains all the people who are healthy, okay? Then we have second compartment, which is the infectious compartment, and the people in this compartment are all sick, so they have the infection. And again, as I said, they are responsible for further spreading the infection as well, because as I mentioned, I am not considering any latent period right now. So it is as soon as they get infection, they start shedding the bacteria, and then they start infecting people as well. And then we have people who are removed or recovered from the chances of getting infection, okay? So there are 3 compartments and each individual in the population is divided into one of these, has to be in one of these 3 compartments. So it either has to be healthy or sick or immune, okay? So which means either susceptible or infected or recovered, right? And as I said, I'm assuming that recovered people cannot catch infection again. So in some case you can also, so some books also refer to them as removed from, which means that removed from the possibility of catching infection, okay? It might contain the people who die because of disease as well. Yeah, I'll talk about it. So now we have 3 compartments in the population, right? S, I and R, and that's why these models are sometimes also called SIR model, okay? Susceptible, infected, recovered. Now when there is an infection, people will start moving within these compartments, right? So we have, let's say, out of 100 people, we have initially let's say we have 95 people are healthy, 5 individuals are infected initially, but then obviously it's not going to be same for, so at t equal to 0, this is the situation. So that's my initial condition, right? So but as time progresses, so let's say at t equal to 1, more people will catch infection, right? And some people who were infected, so who were in this I compartment, will recover and they move to the recovered class. So then the population in these 3 compartments are dynamic, right? They are changing over the time, right? And whenever something is changing over the time, how do we mathematically model it? Differential equations, right? So we write the differential equation of the population in these 3 compartments. So we have a S compartment, which is obviously S is the number of infectious susceptible individual in the population, and it's going to change with time, right? So that's why it's a function of time, right? So then, and then what I'm interested in, how this S is changing with respect to time. So I'm interested in ds by dt. Okay. Similarly, I will also look at di by dt and dr by dt, because I'm interested in how the population in these 3 compartments are changing with respect to time. Okay. So now obviously there is some interaction, they are not independent of each other, right? We have so I'm considering a closed population, so as I said, there is no birth, no death, so there is no inflow in the population, so it's constant, it held constant at 100. And now I'm saying how these different compartment population or numbers in these different compartments are changing over the time. So now I have to understand how the numbers are actually changing, right? How people from this S compartment are going into this I compartment and I to R, right? So how, so essentially what I'm asking is how healthy people are becoming sick. So as I said, I considered that the mode of transmission or the way of catching infection is the direct contact. So I say that when a person who is healthy come in contact with the infected person, they become sick with some probability, obviously, right? So there is so it's a combination of what is the probability that I will come in contact with the infected person, or what is my contact rate, how many people per unit time I am meeting, right? So that's my contact rate. And then what is the probability of me catching infection from a single interaction with the infected person? That is also a probability, right? Now you can, for simplification, consider it to be 1. You just consider that every time I meet a person, every time a sick person come in contact with the infected person, they will get sick, right? Okay. And then again, as I said, I am assuming homogeneous mixing, right? I am considering the population is homogeneous. So I consider each individual is identical. So then, as I said, I consider that each person has same contact rate, right? So each person meet n number of people every day, and this is homogeneous for it's same for uniform for all of them. Okay, so now. Okay, so then now we try to figure out how, as I said, a healthy person becomes sick. So they come in, as I said, they come in contact with the infected person, and that's how they catch the infection, and they move to the infectious class. And that rate at which, so for that there are 2 essential things, right? So first is this I, so there has to be some infected person in the population, and more the infected people, there is more chances of me coming in contact with the infected person. So that's why this rate of transfer of susceptible to infected depends upon I, right? How many infected individuals are there, that's going to increase my chances of catching in contact with the infected person. And then there is beta, which is called the transmission rate. So as I said, this transmission rate is a combination of 2 things. It's my contact rate, which means how many individual I contact per unit time, let's say per day. So that's my contact rate, multiplied by what is the chances of me catching infection or an individual catching infection, followed by a contact with the infected person. So it contains 2 things. One is the contact rate, and other is the transmission probability. Okay, and that we call it transmission rate beta. So and we multiply it with the number of infected individual, because more the infected individual, more are the chances of becoming infected, right? So then with this rate beta I, individuals move from this S compartment to I, right? So then as I said, we are interested in di by d rate of change of population in these compartments. So I am interested in how, and remember these are all function of time, right? I am just going to write S for the sake of simplicity. So di by So what I'm saying is, once a susceptible person come in contact with infected person, they become infected with this rate, right? So this means that, so this is true for one person, right? One susceptible person. So for per capita rate of change of, so per capita rate of change of susceptible individual with respect to time will be what? Minus beta I, right? Right? So what I do is, I don't want to have it like this per capita. I want to write it for general population. So I just multiply both sides with S. Okay. So then it's beta Si. I can take this S here, right? I multiply both sides with S. So then this is, or we generally write it at beta Si. Okay. It's just how we like, I'm accustomed to seeing it, right? So we always write it that way. So then this, and then these people, so rate of change of S with respect to time is minus beta Si, where again remember this S and I are still function of time. These are not constant. They're always evolving. They're always changing, right? Now, okay, I forgot I here. Okay, so obviously we have a population which is closed. So whatever is subtracted from here should be added somewhere, and it's going to be added to this I compartment, right? So it's beta Si, right? And then, yeah, I'm not writing T, but you understand that they are evolving. That's why we are able to find the ds by dt. Otherwise, it will be just constant. So 0 actually. So so this ds by, so now, okay, so I know that what is the inflow in this compartment. Now what is the outflow from this compartment is people recovering, right? So what is the, again, per capita individual recovery rate, if I say gamma, right? So then how many people are recovering is ds by dt will be gamma I, and then these people are recovered or removed from the possibility of catching infection, they will add in here. Okay, so these are my equations for simple SIR model with, as I said, the assumption that I listed, that population is homogeneously mixed, the population is large enough to ignore the individual discrepancies, and then there is low latent period, there is no birth, there is no death, etc., etc., all the things that I listed before. It's still, Shakti, is still 3:30, is it? Okay, I should hurry up. Okay, so then, so as I told you, I think the beta is the transmission rate, and it's combination of the probability as well as the contact rate, and gamma is the recovery rate. So 1 upon gamma is actually the average length of infection. So how long a person remains infectious is 1 upon gamma. Okay. So this is my model here. So how many contacts I make per unit time. So how many days, so for example, how many people I meet in a day?
So would that depend on the density of the population?
So that's what I'm saying, I consider it to be homogeneous, right? It will depend. So then you okay, so you are asking a question that then we have to consider the interaction to be density dependent or frequency dependent. Yeah.
I mean, like you can understand if the density is more,
Yeah.
so there are more chances of interacting.
That is true. But I mean,
Contact rate wouldn't that increase?
it will. So that it's a simplification that I'm saying that regardless of the density, so I'm not taking density. I'm considering that each person has equal probability of coming in contact with the same people in the population, right? So I'm considering that. But again, then we go for so then there are two kind of interaction. Can be density dependent, can be frequency dependent. Right now I'm considering the simplest one. That I consider that it doesn't depend upon the density. Okay, but you can modify it to account for the density as well. Then you have to consider the area and or like all those things. It gets it's just one step ahead. This is a simple interaction. It doesn't depend upon the density. But you are right. There are, as I said, there. It is specified. So there is a frequency dependent transmission, and then there is a interaction, and there is density dependent interaction. Then you have to define SIR also in a slightly different way as a density of the population.
Transmission rate is a combination of contact rate
and transmission probability. So what is the chance that I catch infection if I come in contact with the infected person?
that is somewhat related to the average immunity of the population.
Again, consider it to be homogeneous, right? So as I said, this is the simplest possible model, right? We are making a lot of simplifications here so that in order to get the analytical traceability. You can always relax these assumptions and end up with a slightly different version of this model. Any other questions? Okay. So the equations looks like this again, and with these, so again, this is a system of differential equation which we also call as dynamical system, and then we solve this dynamical system and using some initial condition. Because of the well posedness, we need to know what are the we have to have some initial condition in order to study this mathematically, right? So the initial condition that we use is that initially the susceptible population is greater than 0, right? And then infected individual, there has to be at least one infected individual. If it's 0, then there is no question of epidemic. So we consider this infectious initially at time 0 or t0. There is at least one infected individual in the population, and then recovered, you can consider it to be 0 as well, or you can consider it to be greater than equal to 0. That's up to you. This is a valid initial condition, and with these initial condition, we try to, yes.
The third one is fixed automatically, right? Given n is constant.
Yeah, so one thing that I didn't mention is, yeah, what is it?
I was just saying, if I fix two initial conditions,
Yes,
then third one is automatic.
Yes. Okay, one thing I missed to mention is here. So the total population here, S plus I plus R represented by N, and I am considering N to be constant. So dN by dt will be 0. Okay. So what is the benefit of taking a constant population is because since N is dN by dt is 0, so if I just look at the rate of change of S and rate of change of I, then I can always figure out what is the rate of change of R, right? You can see that from the equations as well. If I just look at these two equations, I don't actually need the third equation in order to figure out, yeah.
Why do you think it has compartments? Like something group spatial compartments?
No, compartment are not in terms of space. We are just labeling individual in a particular class as a particular like susceptible, infected, or it's
Ultimately, it's all mixed, right?
Yeah, it's mixed. So compartment is just a term that we use. Its compartment is all the people in this class. It has nothing to do with the space. It's just labeling a class. Okay, so as I said, population is fixed, so you can just work with the two equation S and I, and then you will be able to figure out R. Okay, so these are the equation, and with these initial conditions, we are going to analyze this dynamical system. So we numerically find the solution of the dynamical system with these initial conditions, and this is what I get. So this is the epidemic curve. So so as you can see, this is how the number of susceptible population will change. So blue shows that over the time how population in S compartment is going to evolve, and red curve shows how the infectious individuals are going to change over the time, and yellow curve shows how the recovered individuals are going to, or number of individual in the recovered compartment are going to change over the time. So this is how the populations are evolving over the time. And as you can see, so we are mostly interested in or what is mostly reported when you are dealing with a real epidemic is this infectious individuals, right? This is the number of cases of a particular disease. So as you can see here, it has this hump shape, so it goes up and then it gradually goes down. So this is a characteristic epidemic trajectory or epidemic curve or shape of an outbreak, right? It has been seen in, but remember that we made the assumptions that it's a short duration epidemic, it's not going to extend. So for example, for COVID you have multiple waves, right? It's the assumption that we made are not valid for COVID, right? Here we are saying that it's a short duration epidemic, it shorts up and then it goes down, because population, most of the people are recovered, so there is no chance of infecting more individuals. They are already immune, so there is another element to it, right? I consider that once you catch immunity, you cannot lose it, right? So which means that once you are recovered, you are immune forever. So if you relax that condition, again you won't see this curve. So this kind of epidemic shape of the epidemic curve has been observed for other epidemics which are of similar characteristic. Although this model is very simple, it actually fits well with the shape of the curve fits well with the sum of the diseases which have, yeah.
long-term residual susceptibility,
Yes.
is that because of the people who never got infected?
Yes. They somehow escaped the epidemic because there's as many people can be infected, right? So say they were just lucky ones, you can say. Okay, so this curve has been observed for similar epidemics. For example, the influenza in an English boarding school. So this is the real data, and you can see that it has that same kind of characteristic curve. And also the plague in Mumbai in 1906. So these two also have the same. So this is again, these two epidemics are short duration, close population, all those characteristic fits, and then they have the same shape. So essentially, you can fit a SIR model to any of these data set and then figure out what is the beta and gamma for these models, because they fit the bill, like they fit perfectly the assumption that we made. Again, as I said, as we relax as the assumptions are relaxed, this model is not going to be enough. Okay, I see.
That graph is not similar to yellow line, right?
No. So these are the people who were recovering the bed, which means that they have not recovered yet. They were in bed.
Okay.
They are not recovered. They are still recovering.
But we do not see any such peak in the recovery rate for.
So actually, if you talk about the infected individual, you have to combine these two, and that will give you the same.
Okay.
Okay, so I'll just quickly walk you through this threshold phenomena which is seen in this epidemic model. So if I just concentrate on the equation of di by dt, because as I said, I'm only interested in mostly what we can observe is the number of cases, right? So we can observe those, and then we try to see what will be the fate of epidemic, can we say something about it. So if you look at the di by dt equation, so equation of infectious individual, you can see that I can write this equation in this way from here, and you can, so from here you can see if let's consider if S0 initial population. So I am now normalizing the population, so I say that I divide the whole population by the total population since it's constant. So now I'm working with the fractions. Does it make sense? Right? So my population is constant, then I have, let's say 50, 30, 20 in each compartment. If I divide it by 100, then I have fractions, right? So I'm dealing with the fractions. So my total population, so that my total population n is going to be 1. Okay? All right? Okay. So if so from here, when the epidemic starts, so initially there will be some susceptible individuals, right? Most likely it will be everyone, it will be susceptible, right, except for 1 or 2. So because if there is a new epidemic, most of the individuals will be susceptible. So that will be my S0, so the initial number of individuals which are susceptible. So if this S0 is less than this gamma by beta, then so initially what will happen here? So this S is now S0 at t equal to 0, then this di by dt will be less than 0, right? So it will be negative, which means your initial, so if this guy which is being infected is less than this gamma by beta, then this quantity becomes negative, right? And then di by dt will be negative. That means what will happen to I? It will decline, right? It will go to 0, right? So it will decline. So as t tends to infinity, I will go to 0, right? So then in this case, if this is true, then the disease dies out because their susceptible individuals are not enough. So what we do is we define this reciprocal of this gamma by beta as R naught, right? And we call this in epidemiology we call it basic reproduction number. Okay, so in this model it's beta upon gamma. And assuming that everyone in the population initially is a susceptible, and a pathogen can invade only if this R naught is greater than 1, right? It's coming from here. So I'm saying that this quantity is reciprocal of here, and if initially everyone is susceptible, then I'm saying that S0 is nearly 1, right? Right? Yes or no will be appreciated.
Yes.
Okay. So I assume this S0 to be 1, right? And then I say that if this quantity beta by gamma is less than so here. So I say that this beta by gamma is the reciprocal of this. So which means that if 1 is less than 1 upon R naught, right? Which means if R naught is greater than 1, then assume, as I said, assuming everyone is infectious, everyone is susceptible initially, then I say that the pathogen can invade only if R naught is greater than 1. Otherwise, what will happen? R naught will be less than 1. This means that this 1 will be less than 1 upon R naught, right? And this means that di by dt will be negative, right? So the a pathogen can invade a population or epidemic can take off only if R naught is greater than 1. Okay. Again, R naught here is the basic reproduction number, and this expression is explicitly for the model that I considered. If I change or tweak my model a little bit, this R naught expression will also change. So R naught will no longer be beta by gamma, it will be something else. But it will still represent the same thing. So whatever R naught you get, this result will be still valid, which is that if R naught is greater than 1, the disease will be endemic, it will invade the population. And another thing is this R naught will always have an element of beta, which is the transmission rate divided by the recovery rate. And as I said, recovery rate is the reciprocal of the infectious period, right? So it's beta times the average infectious period. So it's telling us that how many individuals primary or a typical infected individual will produce secondary infectious cases in its total infectious period, right? So that's essentially the essence of the basic reproduction number. Whatever be the expression, it should have the same physical meaning to it, okay? And this result, as I said, R naught greater than 1, disease will invade the population, R naught less than 1, disease will die out. It's also universal for whatever expression of R naught you have. If it's not happening, that means there is some problem with your expression. Okay, so to make it more concrete, the basic reproduction number, which we denote as R naught, is the average number of secondary cases arising from an average primary or a typical primary case in a entirely susceptible population, because remember, I consider at S0 to be 1, right, when I derived it in the previous slide. So what does it mean physically is that more the R naught, more people, it's the more contagious the disease is. Okay, I'm not even done with the epidemic model, or my time is over. So, so mathematically also it's very, very relevant. So what we see is essentially if I increase the reproduction number, so it's more contagious biologically, obviously that what's it mean, the basic reproduction number. But if basic reproduction number is greater than 1, then you have this disease occurring, right? This number of infectious individual are more than 0. But if basic reproduction number is less than 1, then there is no epidemic. Okay. So from the dynamical system point of view, we have our model system has 2 fixed points. One is disease-free equilibrium, other is or 2 equilibrium points. One is disease-free equilibrium where there is no disease, which is happening here in this area, and then another is the endemic where the disease is persistent, and which is this area. Okay. So what is happening at R naught equal to 0, R naught equal to 1? There is a change in the behavior in the dynamical system. So what happens at R naught equal to 1? What is it's called?
Bifurcation.
The bifurcation point. Okay. Yeah, you have a question.
What do you mean by there's an equilibrium? But there's a definite equilibrium. Because I don't.
Oh, this model doesn't have.
Oh.
But in general, like when you consider birth, then you will have to take 2 equilibrium. Okay, disease with obviously different value of R naught generates outbreak of different shapes. So the shape of the outbreak is also given by the R naught. So if your R naught is less, your disease will be like your peak of the disease will be much later, and it will be a damped one. So and if R naught is high, your disease will shot up immediately, and then the peak of the disease will come early, and then it will wane off, right? So although it can happen that the area under the curve is same, so which means that disease will infect the same amount of people, the peak will happen if R naught is greater, it will be much higher and will happen much earlier. So from public health point of view, it is important because you remember, like during the initial COVID days, everyone was talking about the flattening of curve, right? So if your curve is flattened, then it will never, your number of infected individual never reach the limit that we have for public health, right? So as I said, although the number of individual which will be affected by the disease will be equal, but we will be able to manage the epidemic in a much more better or prepared way if the disease follows this curve, like if the curve is more flattened, right? So here, So if you have a flatter curve, then you will never go above, the number of cases will never go above the limit of the healthcare system, so the healthcare capacity. Okay. So that's why there was a lot of effort on reducing. So whenever we're dealing with the disease control, we are always concerned about reducing this R naught, right? Because that is what is going to affect how the curve is going to look, right? So what we derived here is the basic reproduction number, where I assume that S0 is 1, right? But when the epidemic, so this helps us understand whether the epidemic will, there will be outbreak or there will be no outbreak. But once the disease has already invaded the population, then we talk about something called the effective reproduction number, where instead of considering, so it, for example, for this model, it will be beta by gamma ST, right? So instead of considering to be the initial condition S0, it is ST. So then again, there could be many extensions of this SIR model. You can consider, as I said, we relax the condition that we have. You can consider a SIRS model, where people after recovery, after some time they lose their immunity, they become susceptible again. Then there is SIS, where there is no immunity at all. Once you infected, then you again become susceptible, so which means you can catch infection again. Then there is this SEIR model. As I said, this is the model where we take into consideration the latent period as well. So E is the exposed class, and these are the individuals which are infected but not yet infectious. So the people in this class, so what happens is when I come in contact with S, they move to E, they stay there for, let's say, 2 or 3 days, and then they move to the infectious class. So they are infected but not infectious, that's the latent period. And then you can categorize I into 2 compartments. Like for COVID, there was pre-symptomatic and symptomatic, right? So for HIV/AIDS, there is people with HIV and then full-blown AIDS, right? So you can compartmentalize the I compartment, and you can go on, like you can go do it like for nth compartments. It's up to you how complicated you want your model to be. In addition to that, you can always have the birth and death in the model. So how we account for that is, again, there are 2 ways of doing it. One is we still keep the population constant but not closed. Okay. So what we consider here is a closed population. There is no inflow and no outflow, but I can always say that there is a inflow of the population, right? And then it is balanced by the outflow of the population, right? So I add this much and then I subtract. Okay, this is something different. Right. So even in this case, my population is constant, right? Because S plus I plus R is N, right? So dN by dt is still 0, but the population is now has birth and death. So this is the birth rate and this is the death rate. So it's balanced by birth is balanced by death. Then again, you can go one step ahead. You can say that okay, the birth and death are not same; they are different. Then I can always have disease-induced mortality. So I can always say that the mortality or the death rate of the infected individual, some people might die because of the disease, right? So there will be an additional, so it will not be just mu, it will be something like mu plus alpha times I, right? And then I can, as I said, I can say that okay, the population does not depend upon N at all, it's a constant inflow of population. So I consider it to be some new constant A, which is the rate at which the population is coming into, new individuals are coming into population, which is regardless of whatever the population is. Yes. Yes, R naught, as I said, R naught will change. So for this model, R naught will be different. Okay? But essentially it will still, as I said, it will still hold the same idea that, so as I can just say that R naught in this case will be this beta divided by what is the average infectious period, right? So which is gamma plus mu plus alpha in this case. So the essence will remain the same, expression, mathematical expression will be different, and it will still represent the same, the mathematical result will hold. Okay. So maybe we'll talk about the second question after the tea break. So now that we have an idea as to how do we model the outbreaks mathematically, and as I said, this is the simplest model. You can expand it in any way as you want, but I'm going to stick with the simple model and then now try to modify it, because as I said, transparency of the model is very important for me, and also the analytical traceability. So if I make my model more complicated, then I will probably not able to understand. So if I have 100 parameters, I wouldn't be able to pinpoint why, if I'm seeing some change, why is it, like what parameter is causing it, because I have 100 parameters, right? So first part we have already dealt with as to how do we model the outbreak mathematically. Now what we are going to do is, we are trying to answer if we can modify these model to include the behavioral changes, as to, and how do we actually do that. The answer is obviously yes, because as I said, I did my PhD in this area, but how do we do that is what we are going to discuss maybe in the next talk. Okay, any questions? All right, yeah.
This is S, I, and R. What is the unit? It's all numbers.
Yeah. These are numbers. You can use the fractions also, it can be density, depends on how we define it, and accordingly this interaction term will be different. Right now I'm considering 3 numbers. If I consider
Deterministic models of, I mean, in chemical reactions, we work with concentrations, right?
yes, so as I said, if it's density, then this beta Si will be defined in a different way. So there will be an n. We have to normalize it with the total population. So there will be an n. So the interaction term will depend upon what you are considering this B, S, I, and R to be number, fraction, or density.
Yeah, but the base will also change depending on the volume size.
The rate, you mean this gamma will be?
Beta.
So yeah, so then so beta will change, right? As I said, this interaction term will be different if I consider it to be density. It will not be beta Si. We have to define it in a different way. It's a simple interaction. Then you will have to go for density dependent interaction. And if you consider these to be frequency, then you have to go for frequency dependent interaction. Then there will be some additional terms, and sometimes they cancel also. Okay. Any other questions? Yeah.
When you first wrote gamma, I thought it's how fast we manage to get people from infected class to recovered class. But now it seems some property of the virus.
It's an infectious, it's a recovery rate, right? So how, it means how fast individuals recover. So at what rate people are recovering from the disease and moving back to this recovered class. So this, if you derive that expression, it actually comes out to be 1 upon the total infectious period. So how long they were infectious.
Is it some property of the virus, like after some time it's going to?
It is, right, because we are considering that after some time people recover from it, right? I'm not saying that people will die there. Even if they die, so they are going to spend some time in that compartment. So this is reciprocal of that. Okay, so the lifespan that they spend in this compartment, 1 upon that is going to be this.
The medicine, the treatment.
This will increase that. You can, in principle, consider this to be like innate recovery rate, and then you add another term for treatment. If you are considering treatment also dynamic, right, and you consider that all people don't have access to the treatment, then accordingly you have to modify this recovery rate. But here I am considering that everyone, it's like one health, everyone has access to good treatment, and on average they have same immunity level. So on average they all recover they spend like 6 days infected. So then 1 upon 6 is how the rate with which people leave this class and move on to the recovered class. Okay.